This conference will now be recorded.
Hi, everyone. Welcome to the March 2021, I can't even believe we're saying that, RMC Monthly Support Group meeting. We have two very special guests with us, but before we introduce them, and Richie's going to do an excellent job, I want to go around the room real quick and kind of check in with everybody. So, hi, April. Two things I want to ask you. Do you need time tonight? Is there anything you would like to say tonight? And how can we support you?
As of right now, everything is okay. I think just the
Everything's
fact that the community is out there is a real big support.
Okay, perfect. Hi, Zan. I'll ask you the same two questions. Do you need time tonight to say anything? And how can we support you tonight?
Yeah, well, I was talking to Richie. I got in contact with her. So I also run a research foundation, the RMCRF. So I lost a friend, Rise Williams, basketball teammate, my freshman year of high school, and I started a nonprofit, and that's just kind of how I ended up here. And it's really nice. You know, it's a small community, but it's a very tight knit community of people who really care about RMC.
Exactly. And that's why I love this community so much. We have one big goal in mind. Hi, Carissa. Good to see you. Anything on your mind tonight, and how can we support you?
Yeah, I had a question I would like to discuss today, Alexa.
Okay, then we will definitely get back to you on that. And any way specifically we can support you?
Sorry, mic was on mute. No, I appreciate everybody being on here. I'm excited for our meeting.
Sure, perfect. Hi, Karen. Good to see you. Do you need time tonight? And how can we support you?
Hey,
No, I'm okay. I don't need any time.
Okay, perfect. Well, we're glad to see you. Hi, Lori. Can you hear me?
Yes, I can.
Okay, hi, Lori. Do you need some time tonight? And how can we support you?
No, we're looking forward to hearing the doctor speak. And no, we don't need time tonight. Thanks.
Okay, perfect. Nicola, do you need any time tonight? And how can we support you?
Hi, I'm from the UK. No, I've just come along to listen to everyone and get some information as much as I can. I lost my husband nearly 2 years ago now, and I've just set up a foundation in the UK to raise funds and awareness. And yeah, so I'm just here for everybody else as well.
And we're so glad you're here because it's a real sacrifice for you to come because it's so late.
It is. It is.
It's very late.
It's fine. It's absolutely fine.
Well, thank you so much for coming. And Andre, I don't know if you can hear us, but just want to check in if you can.
Yeah, I can hear you.
Okay.
Yeah, I don't need no time tonight.
Okay. All right, perfect. And then Diana and Danielle are here. They're coming. They're in process. So what I would say we would do, we can definitely circle back to them, is Richie, would you please introduce our very esteemed guest tonight, who we have a whole fan club here for them.
Oh, yes, I'll be honored. I'm just so happy to have Dr. Masal and Dr. Sapira with us tonight. And just to give you a little brief bio for each one, Dr. Pablo Masal is a clinician and cancer biologist dedicated to laboratory and clinical research for kidney cancers, with a particular focus on rare variants such as renal medullary carcinoma. He received his MD and PhD in cellular and molecular physiology from the University of Athens in Greece. He then completed his internal medicine residency at the Albert Einstein College of Medicine, Jacobi Medical Center, and also served as chief resident for the program. He subsequently served as chief fellow at MD Anderson Cancer Center while completing his fellowship in medical oncology. He is currently an assistant professor of oncology at the University of Texas MD Anderson Cancer Center. And then we also have Dr. Daniel Shapiro. He's currently a urologic oncology fellow at the University of Texas MD Anderson Cancer Center. He received his MD at the University of Wisconsin School of Medicine and Public Health. He then completed his general surgery internship and urology residency at the University of Wisconsin Hospitals and Clinics. After fellowship, he has accepted a position as an assistant professor of urology at the University of Wisconsin, serving clinically at both the University Hospital and VA Medical Center in Madison, Wisconsin. He plans to continue clinical and translational research of kidney cancer. We're just so happy to have both of you here with us tonight, and this is the opportunity for everyone to ask all the questions that you have once they finish their talk. So would you like for them to start now, Alexa? How are we going to do that?
Who wants to go first?
Well, a pleasure seeing you all. I know many of you, some of you I've met in person, and some of you electronically via email. So it's a pleasure connecting with you guys. A major reason why we wanted to be here with you guys, and we honestly wish we could be here all the time. And I think this is a wonderful initiative, and it makes a huge difference for RMC. You know, for many years, an invisible disease that now is becoming visible step by step. And part of, you know, making this disease visible, which was a mystery for many years, decades, you know, this disease was a mystery. We are with our research group and with many people, including Dr. Shapiro, who is also here with us today, we are now beginning to unravel this mystery, and we're beginning to understand it more and more. And again, this is through efforts supported by communities like this one here. But as we begin to learn more about RMC, questions naturally emerge. It's only natural that as soon as we get some answers, there will be many more questions that emerge. And so with this being, you know, close to Rare Disease Day, and with this being Kidney Cancer Awareness Month, and with the Renal Medullary Carcinoma Walk happening in the next few weeks, and with this recent publication, which still has not been peer-reviewed, I want to highlight that. So it still, you know, needs to be reviewed by other scientists and go through the regular scientific channels. But this is an effort that was led by Dan Shapiro and Melinda Shong, who is a PhD student studying why RMC happens. And one of the things that we discovered and we felt we had to share it with the community even before it got published in a journal. And I think it ended up being a good idea that we share with the community, because already communities like this one is giving us great feedback and ideas. And so the discovery is that we have found that high intensity exercise may be a risk factor for RMC in the setting of sickle cell trait. So we always wondered why RMC tends to happen more in some people with sickle cell trait and not others. And we believe that a connecting thread amongst many individuals, not everyone, it never is that simple that everyone will have that risk factor, but many, is a certain type of high intensity exercise. And that's one key thing, because we wanted to be very careful with the messaging here. The last thing that you want to tell the sickle cell trait community is exercise is bad because it can cause cancer. That's not the case at all. Actually, if anything, and Dr. Shapiro will share, more data and information, we're finding that moderate exercise is good. It may actually help prevent RMC. It's high intensity exercise that we seem to be finding increases the risk, and a sedentary lifestyle. So if you don't exercise at all, you're worse off. If you exercise with very high intensity, that may increase your risk of RMC. If you're doing this in moderation or carefully, and we will in the coming months and years tease out more what carefully means, we might be able to prevent this cancer. So this may be the first time we actually have a clue how to prevent this cancer. So this is something that I recall, I'll never forget, in 2017 when we did the RMC Alliance meeting in Washington. Ritzy Johnson and Cora Connor and Wanda Powell, all three of them said the one thing that we want to do about RMC more than anything is to find out how to prevent it, how to diagnose it early, how to screen for it. That's what they pleaded for. And I will never forget it, because I thought that this is like impossible. Like, it felt like climbing Mount Everest. But it stuck. And I think that finally we may have a lead. It's going to take a long time and a lot of processing and digesting the information, a lot of work, including by the RMC Alliance. But we may have a lead on how to screen certain populations that are high risk, give certain recommendations, etc. So with this exciting but findings that generate questions, that's why we wanted to be here, because we shared this with the community and we're certain there are going to be questions by the community that we'll be happy to answer.
Yeah, and I can jump in and just, echo exactly what Dr. Masul is saying. And, it brings to mind when I started my training, we have to learn about each disease. And renal medullary carcinoma, we have a big review book, that we look at before we take tests. And renal medullary carcinoma in our review consisted of one line, and it said, occurs in young people who usually have sickle cell trait. And that was about it. And so I think what Dr. Masul is saying is absolutely correct, that it's great that there's communities like this that raise awareness and help each other through, difficult times or dealing with a new diagnosis like this. And also raise awareness, which, I think is one of the most important things you can do with a disease. And I think the research that we're doing, and I can talk more about that, we're starting to tease out, like you said, possible modifiable risk factors. So it's one thing to understand how to treat a disease after you've already gotten it, which can be very difficult. And in the case of renal medullary carcinoma, it's extremely difficult to treat. But if you can prevent it in the first place, that really is the holy grail of cancer management. And so I think the research we're doing right now is, like Dr. Masul said, is the first step in the right direction in starting to raise awareness and also potentially help prevent this disease from occurring. So I don't know if we want to, I can maybe talk briefly about the recent research that we've done, or we can answer questions or whatever you guys think is best.
What's interesting, I would just like to say a little bit, what's interesting is that I was talking to Dr. Tanier years ago, and I shared this with Dr. Masul. And I asked, I said, do you think that physical activity, exertion had anything to do with REMC? And at the time, he said, well, I don't think so. I said, but you know, it's really strange. I said, all these kids play ball, they play football, basketball, or some type of strenuous activity. I said, something, it's a correlation, just like they all had sickle cell trait. I said, those are two common denominators, and I just honestly feel that has an impact on it. So now this just clarified what I felt all the time,
Good
and I
job,
appreciate
Richie.
that.
Yeah, and I think, you know, as surgeons and physicians and scientists, we're naturally skeptical of new ideas. But I think, you know, we started to recognize the correlation as well. And then Dr. Masoul and myself and other members of our team really started to run with that idea. And, you know, the data just kept adding up. And so we first started clinically, kind of like what you're saying, looking at all the patients that we've treated. And Dr. Masoul has treated probably more than most people in the world. And we looked through our data at all the different patients, and we're like, you know, this correlation really does exist. There does appear to be a large proportion of the patients we're treating with RMC who have participated in athletic activities, and not just, you know, I was involved in, you know, club sports, but like high level athletes and people who were really doing high intensity exercise. And I think, like Dr. Masoul was saying, that's really what we want to highlight, is how that this is really related to more high intensity exercise and how we can prevent that and do it safely, so that we don't, you know, exercise in a manner that isn't safe. But we don't want to get the message out that you shouldn't exercise at all, because that's actually counter to what we've seen in some of the mouse data, that some moderate intensity exercise may actually be helpful.
Yeah, I think that, you know, honestly, and I'll be honest with you guys, I think that exercise is so important. And it's so important also, you know, to the African community and the sickle cell trait community, that even if all exercise was a risk factor, I would still say that exercise is worth it. You know what I'm saying? But we can just try and screen and you know, diagnose it early, because exercise is such a big deal. Like, if you stop exercising, you're gonna harm the community. But the nice thing, and I will say this, guys, like, RMC is a cruel disease. Like, it truly is a cruel disease. And it became 10 times more cruel when we identified that, listen, you know, like, the thing that parents have their children and encourage them to do may be something that may cause harm. Like, how much more cruel can it get than that? But the silver lining in all of this, thankfully, is that we are seeing that moderate exercise is actually helpful. So we don't even need to say, oh, all exercise, you know, can increase the risk for RMC. Let's be careful with it. We actually can say, if you do exercise in moderation, you may actually prevent RMC.
It's an opportunity for education, for sure.
Now, the other key thing is this. In the sickle cell trait community, there has been this notion that you have to be careful with exercise. It's been something that it's not widely known and as widely known as it should be, but it's becoming more and more common knowledge. And the reasoning why is because it has been noticed, and that was noticed also in the military, whereby it was one of the first times when it was noticed that if you had sickle cell trait and were in the military, you were more likely to have, you know, sudden death. Like, your heart would stop and then you would die, you know, an increased risk. Not a hugely increased risk, but there was a signal. That was the first clue. And then you would see athletes that would have this thing happen as well, you know, sudden death. because they had a sickle cell trait, or they would have muscle breakdown. That's the reason why professional athletic associations started saying, and the military started saying, check for sickle cell trait, because they want to detect these things. And so when they notice these things, they're rare. These are rare events, as RMC is. RMC is also rare. These are rare events. They don't happen to everybody with trait, but they can happen. When they started noticing these things, they started making slowly and gradually guidelines on how to do exercise, including being a professional athlete or being in the military, but with reducing the chances and preventing the risk for sudden cardiac death or muscle breakdown. Well, now we can add one more thing that we can prevent with these strategies, and that can be RMC.
Well, I have a question for Dr. Massal and Dr. Shapiro. What would be considered intense exercise? I have like a sister who's like is like ran the New York City Marathon and loves doing CrossFit. Like, would those be considered like intense exercises?
Dan, you'd like to answer this?
Yeah, I think it's not so much the type of exercise, it's how you go about doing it. So essentially, you don't want to be doing exercise that you aren't accustomed to and performing it at very high rates of intensity without any sort of training. So the big thing is gradual increases in intensity. And then also you want to be staying very well hydrated. So you should be pre-hydrating before you exercise, drinking, up to 20 ounces 3 to 4 hours before. You also want to be taking frequent breaks during the exercise to continue hydration, or hydrating while you're running, things like that. And then also staying hydrated afterwards. So there are very specific guidelines that you can follow, and there's a bunch of different resources available through the CDC and also the NCAA, and different athletic organizations have sort of safe athlete regimens. And also, you don't want to be exercising in extremely hot or humid weather. So it's not so much the type of exercise activity, it's just how safe you're doing it. So, all of a sudden going from the couch and then deciding you're going to run a 5K with no training, that's probably not what we'd recommend if you have sickle cell trait. Now, if you can gradually increase your exercise and sort of train yourself to become accustomed to that, then that's more of a safe way to do it.
Sure.
Yeah, that's very helpful. Thank you, guys.
Yeah.
I had a quick question if no one has one. So as far as screening goes, what do you guys have, like, what's like the thought process behind that? Like, I've read about it before, but I just want to hear from you guys.
So Dan, you want to answer that first?
Yeah, I think screening is important. I think there's a lot of different lifestyle modifications that can be helpful, like what we're talking about here with exercise. And understanding, I think, is beneficial overall from a health standpoint. So Dr. Masul, if you have any additional thoughts about that.
Yeah, so screening is a thing that we have to be very careful with. Why? Because a lot of people with sickle cell trait will never develop RMC. And the problem is that if we start screening everybody, if you do to me right now a CT scan, I can guarantee to you you're going to find something. Like if you do it right now, it's a given. There's all of us after we're older than 20, we have something that's unusual. And so if we start screening everybody, let's say with sickle cell trait, we're going to find things that look suspicious, and then we're going to go down a path that can be harmful. And I've seen that many times. And we have to be careful with this. Now, that's one dimension. The other thing, even, the radiation from the CT scan, because ultrasounds are not that sensitive, it's something to keep in mind. Radiation itself can cause cancer. So we may end up harming people if we're not careful with screening. But the more we become able to tease out which are the high-risk groups that are more likely than others to develop RMC, and that's the key that we're now gradually learning, the more we might be able to maybe do screening in a more targeted fashion. That's number one. But more importantly, diagnose it early. And here are two scenarios that I've heard in the past 2 months alone. Two scenarios, like literally. So many people, and many people even here, but very likely, don't know they have the trait. So there's a lot of people who don't know they have the trait, and they learn that they have the trait after they get diagnosed with RMC. Well, now that we know the exercise story, and we know already, what do we know? RMC is more likely to happen if you're young, in your 20s, if usually, you have the sickle cell trait if you're Black, not always. There are many Caucasians as well, and there are Latinos, Hispanics, but mainly it's Blacks. So if you're young, if you're Black, and if you're male, so RMC is more common in men than women. And where does RMC happen more commonly? 3 times more commonly in the right kidney. So now we've narrowed it down. If you're young, if you're Black, male, with the right kidney tumor, and now we have an additional piece of information. If you are highly athletic, 5 pieces of information. You see that type of person with that history in the ER, they come in with blood in their urine, and they tell you, you do an ultrasound or a CT scan and you find a mass. That's RMC until proven otherwise. You don't need to know their sickle cell traits history, because they might not know it either. And in those 2 cases, they didn't. And what happened was nobody thought of it. They had RMC. They didn't get, the proper treatment that you would need to get if you have RMC, and things can get bad. So as we become more knowledgeable about, who is more likely to have RMC than others, and as we spread awareness, both to the scientific community, so that physicians and urologists, so that the book of future urologists, that book that Dan mentioned, will not just write a single line, but will write, a paragraph or even a chapter about this. So as we do this, and at the same time as you guys spread awareness to the community at large, to the sickle cell trait community, but also to all the overall patient community, then we're going to be able to help these patients in a timely fashion, possibly before even the disease spreads to other organs, and cure them.
So can I just ask a question? Well, it's more about going back to the exercise. My husband was 48, a firefighter, and played football, but not as a professional. And so, I mean, we didn't actually know that he had sickle cell. We're just presuming that he didn't get tested. So what are your thoughts around that?
Good question. So it's possible, I never met your husband, but and I wouldn't even know about any of the things that I mentioned, or I didn't know about the exercise connection for sure years ago. But nowadays, what we're learning is that when you see somebody who has reasons, knowing who has reasons to be athletic, or who has reasons to exercise more, like if they're in the military or in a very active kind of work environment, and if you know their exercise history, and nowadays I think we should elicit that. We should ask people, because one of the things that we found, even at MD Anderson, that's what we did with Dan. We found that we didn't know about a lot of these patients because nobody asked. And what happened is that when we look back, we couldn't tell which one of which for some of these patients, if they did have an athletic history or an exercise history. But what we did is we actually measured their muscle mass, which is objective, like you can't hide that. And we found that their muscle mass was way higher than it should have been, you know, on average. And then we actually started asking patients prospectively about their history, and we find out that, you know, 70% of them or some number like that actually have such a history. We still, you know, it doesn't mean that, you know, you're a firefighter and you're at increased risk yet. And we're still learning, as Dan said, you know, we're figuring out ways to recommend exercise regimens and activity regimens that are going to be safe. But nowadays, I would have asked your husband, you know, what is their occupation and how much do they exercise on a weekly basis? And if, you know, they told me yes to these questions, I would think it may be RMC, even if I didn't know about the sickle cell trait connection. That's the key now.
Okay.
I have a question. I have a question.
Good, Karen.
Is it different for women than men? Because I'm not an athlete, and the only thing that I had going on in my life was just being a busy mom, working, a lot of stress. So does that trigger it as well?
Beautiful question. So I'm really glad you're asking this. So the one thing to keep in mind that is that this connection is kind of like smoking, let's say, in lung cancer. You know, a lot of people who have lung cancer, they smoke, but some have lung cancer and they never smoked. In the same manner, some people will develop RMC and they will have zero exercise history. Now, does that mean that there may not be other things that are connected? We are seeing, by the way, you know, at least some women who develop RMC do have a very strong exercise history. So it seems to be both men and women. But there might be other secondary risk factors that we have yet to fully identify. And we have some ideas and we're exploring them with Dr. Shapiro and others. But the strongest one that we have certainly identified is that exercise activity in the setting of sickle cell trait, of course. Now, keep in mind that even sickle cell trait itself, or any sickle hemoglobinopathy, is not 100% associated with RMC. There are 5%, let's say, of RMC cases, and there might be, you know, people even in this room that might recall of some of them, that don't have the trait or any sickle hemoglobinopathy. So even that is not a 100% rule.
Okay.
I would like to get in a question from Diana and Danielle. They live in a place with 1,800-mile altitude, but Colombia, where they live, actually can go a lot higher than that. Could that be an issue with RMC of altitudes? Or is that
What a
something we don't know?
lovely question, beautiful question. And this is the kind of brainstorming that, you know, the feedback we get from the community. And Dan, do you want to answer this?
Yeah, I think typically, and obviously, you know, we don't have a lot of data to support, or, you know, we can't say for sure, but I think typically if you're accustomed to those altitudes, your body is sort of able to compensate. And so if you live there and grew up there, then usually your body is able to handle the altitude. However, if I was to say go from ground level or swamp level in Houston and go up to a high altitude, I would be more affected by it because my body is not accustomed to that. My red blood cells don't hold oxygen the same way. So it might affect me more than someone who lives at that altitude all year round. And that's another thing, you know, when thinking about exercise, you know, they've seen even small changes in altitude If you normally train in Houston, but then you go and do a competition in Denver, which is much higher in altitude, that might affect you a little bit more significantly. And so those are kind of things to keep in the back of your mind. But I think, and Dr. Masoul can comment further, but I think usually if you're living at that altitude for long periods of time, you should be okay.
And Diana and Danielle, just since I'm sensitive to the fact that English is your second language, did you understand that okay?
Yeah,
Oh, I think I froze.
you're muted right now. Unmute yourself. Daniel.
Right. Oh, thank you. Thank you. Yes, within we understood.
Okay, perfect.
Well, I actually have a follow-up on that to Dr. Dan. And I years ago when I was traveling a lot, I was running a lot, 2,000 to 3,000 miles a year. I'd go between Denver and New York, and it would always take me a day, at least a day in Denver, to acclimatize, and I'd finish up with a headache. But I'm wondering, does the altitude affect your ability to stay hydrated? Or, I mean, the amount of water that you need, that the body needs at altitude, is that different or changed? Because I know from listening to Dr. Masoul and other presentations that that hydration is a very important factor over long term with RMC.
Yeah, it tends to not be so much hydration is the issue. Obviously, staying well hydrated is important, but it's more of your blood's ability to oxygenate your tissues around your body. And we know that the inside of the kidney, where renal medullary carcinoma develops, is already prone to having very low levels of oxygen, which makes it a very harsh environment. And so when you then add in the factor of, all of a sudden exercising at altitude, like you said, you kind of can't exercise as easily, you have headaches, you don't feel as good. That's because your body's not oxygenating as well as it is able to in its normal environment. So staying hydrated is important, but it's more of gradually acclimatizing yourself to that new altitude and not, all of a sudden doing your hardest intensity exercise in this new environment.
But if you lived at that altitude all the time, you don't think it would make any difference to the oxygen levels that your body survives with? I mean, it's a physiological question about.
Yeah, so people who live at altitude actually have hemoglobin levels that are more adapted to oxygenating their body when they're dealing with an environment that doesn't have as much oxygen available. If you think about Mount Everest and the Sherpas, their bodies are adjusted to climbing Mount Everest, so they can go up the mountain without needing oxygen tanks. Whereas if, the normal English climber goes to Mount Everest, he's going to be suffocating at the top.
That's very interesting. And I also have a question on behalf of Nicola, Dr. M. So I know Nicola's been trying hard. They're raising money for RMC in the UK. And Nicola's been looking for access to the Marsden or a similar institution to start working there. Have you got any contacts or tips or anybody in the UK that you might like to do a research study with, and you might need some pocket funding to get the approval?
Yeah, and I'm glad you're asking this question as well, because, RMC was for a long time, and it still is in some ways, a little bit of a lonely place. And what you want is to generate the interest, like make a fire and spread it. not just spread it, not just in Houston and at MD Anderson, but everywhere, and in the UK and everywhere, and also create debates. Because you want that. You want, independent centers and people talking about RMC and thinking about RMC and moving this forward. That's exactly what we want. And I think that the more we keep, doing the research that we're doing and showing that, hey, this is an experiment of nature. I'm talking now just from a scientific standpoint that can teach us a lot about how cancer works, then we generate interest. And having said that, there is some phenomenal kidney cancer research happening in the UK. Phenomenal overall. And actually, we did show, because, for example, we respect him so much, we presented the exercise story to Dr. Charles Swanton from the UK. He is an expert. He is a medical oncologist expert in cancer evolution. And we wanted, his thoughts before we released to the public, and, he gave us some very useful feedback. And, along these lines, he has, for example, a team of people that are interested in kidney cancer and we're working with, and many others as well. So feel free to get in touch with me at any point in time, drop me an email, and I can connect you with people that are generating interest in doing stuff for RMC. We have other people in Europe as well. For example, Gabby Malouf, my alter ego in France, like a brother to me. He helped me immensely, and he helped our group when we did the molecular profiling of RMC. So that was another major step. We published this, last year in 2020, where we analyzed the genome of RMC and learned some really interesting things. Right? And this is the kind of research that, people cannot ignore. So, they read it and they're like, oh, look at this. This is a cancer that I'm not going to just write a sentence about next time in the books.
Where is Dr. Swanson, Dr. M?
So he is, and I'm gonna send you his information. He is in they call the organization Cancer UK. I'm gonna send you more information about it.
Okay. Well, Nicola,
put it on the chat.
Yeah.
On the
Nicola, follow up with Dr. M. Here's your big chance. Go.
Yeah, so I think you've actually maybe had emails from me before when my husband was poorly, Dr. Mansell, and I've got an oncologist with me now on board, a trustee of mine in the charity, and he's a renal at the Christie in Manchester. And he has worked, apparently, Rick, when I followed up on our emails, he has worked at the Marsden. So obviously, I think the renal community in the UK are quite small. So they tend to know each other, and I guess we, as a new charity, don't know where to go at the moment from here, because it's not really known, as big as you guys, and even in the sickle cell community, they're not aware of. It's not really mentioned. Kidney cancer's not really mentioned, or RMC. So it's again, where do we start, really? So yeah, we're raising funds, we're raising awareness, but we need to get in with, I think personally, into the medical team and help towards spreading the word, like you say, and it's what we do really from there.
Yeah, just send us a message. I send the link for Dr. Swanton, but send us a message. We're happy. Even today, I was talking with our research group on how we can work with some other people from a different place in the country who are interested in doing some interesting stuff that could involve RMC. Always happy to collaborate with people. Like if there's somebody in the UK that has a great idea, or if you guys have some kind of funding that you want to funnel in an interesting RMC specific idea, happy to find people that might be able to help answer questions and move the field forward. I think that you push and they'll listen. and they'll
Yeah.
listen, and things will happen. You have to. And even now, one of the things that, it's on my mind, how do we make the next trial that's RMC specific that, we will have in Houston? It had to go through a lot of work and a lot of begging, and a lot of pushing, but we're going to do it. And hopefully in the next few years, we will be able to do the other big thing that we really want to do, to be able to open these trials all over the country, not just in Houston, so that people won't have to travel here, and maybe one day all over the world.
Yeah, because it took Rick 5.5 months to get a diagnosis, and at the Christie, which is a cancer centre, a hospital, specialised hospital, I think he was the first one in 6 years to even, come through the centre. So we didn't really stand a chance with he was stage 4. He was really, really poorly. And yeah, all they could do really was treat him with some chemotherapy. So we've not even heard of anyone else since come through the Christie, in like nearly 2 years. So people are obviously still getting these things and not, and they're being missed, maybe. So yeah.
Oh, I agree with you. I completely agree with you. The one thing that we were always certain, like it made no sense. Why are we keep diagnosing RMC in the U.S. and the more we raise awareness, the more we realize that it's more common than we thought. It's not a super common disease by any means. It's still a rare disease, but it's much more common than we thought. I think that it's 10 times more common than we used to think even 5 years ago in the U.S. And 5 years ago in the U.S., we still had, a better understanding than what was happening outside in the outside world. There are 300 million people with sickle cell trait in the world. There is only, 3 million people with sickle cell trait in the U.S. And I have zero doubt that, in places like Nigeria, there are a lot of people who will have to struggle with RMC, and practically all of them will never find out that they have RMC. I was always wondering, I knew, like, we wrote a book chapter about a few years ago about RMC. It was in a rare kidney cancers book, and we, led by my mentor, Nizar Tanir. And in that, he said, let's write a very thorough book chapter about RMC so that people who read this book can have a whole chapter about RMC. And so in that book chapter, we wrote very specifically about the prevalence, like how common sickle cell trait is around the world. And one of the places where there is a high percentage of sickle cell trait in some populations, in some areas, is my home country, Greece. And we wrote that in the book. And I said to the others, I'm like, we've never heard of RMC in Greece, but that cannot be. It's just that people don't know about it. And as now more awareness is being raised, as you guys correctly pointed out, now we're finding out that RMC, can happen in Greece as well, and is diagnosed there. So this is why it's so important to raise awareness. And, the other key thing is that slowly, step by step, very, very slowly, we are becoming better at, treating patients with RMC. And there are some that do survive, even with stage 4. There is, let's say, a 5 to 10% nowadays that we're able to kill all of the cancer in their bodies. And the goal is to make that 5 to 10% 100%. And that's, the ultimate goal. It will take years. I'm not going to sugarcoat it. RMC is very challenging, but we will get there. Step by step, we will get there. And nowadays, we have some better therapies that give people a higher chance than we did 3 or 5 years ago. And even if we're not able to cure some patients, we're now better able to at least prolong their lives with better quality of life than what was happening 5 or 10 years ago, when, it used to be that the average survival of RMC was 3 months. And then it became 13 months and then 18 months, and now we're getting to 2 years. So step by step, we will get there.
Nicola, I just want to make sure that you found that link in the chat. It's a little kind of speech bubble. At the top, there's some.
Oh, yeah. Let's have a look.
Okay, perfect. And actually, we do have some people from Greece on this call, and I'm sure would love to ask a couple of questions as well. I would like to put my advocate hat on for just a second. And we have in this room tonight, and we have some others who aren't here tonight, who are parents of younger people 16 under with RMC. And I know, since I'm a young adult cancer survivor myself, my cancer was harder on my mom than it was on me. And especially when we're having the topic of exercise and the boundaries of that, and you'd even mentioned that it's hard to balance anything, and especially you don't know what you don't know. I would really appreciate if we could encourage these parents and have two of some of the best RMC doctors in terms of knowledge say that, it wasn't their fault, essentially. I think that would be great.
100%. It wasn't anybody. This cancer is nobody's fault. We had no idea about this up until, a very short time ago. And even now, we're still finding out how to actionalize it. This was no one's fault. No one's fault. I cannot emphasize that enough.
Yeah, I think, dealing with cancer, as a clinician, I think the hardest thing is dealing with a patient who feels like it was their fault that they got the cancer. And as, physicians and scientists, we understand how cancer works and how it has nothing to do with, what you did, or, it wasn't your fault, essentially. This is just biology, and this is what happens, and there's nothing you could do or do differently. And I think we need to raise awareness so that we can implement these preventative measures, so that you don't have to deal with the thoughts that, I caused this, or I caused this to happen in my children. I think we understand that as physicians, that this has nothing to do with what you did, or, anything like that. So I think that's a really important message, and I'm really glad you brought that up, because that can be some of the hardest thoughts that patients have, is these feelings of guilt. And so we need to reinforce that this is not anyone's fault.
Absolutely.
As a parent, though, I have sickle cell trait, and I often said, had it not been for me, Chris wouldn't have had sickle cell trait. So you do have those guilt feelings that still, trigger my mind daily. Had it not been for me.
I think, so I have polycystic kidney disease, which is also a genetic disorder, and it's passed from parents to their children, similar to sickle cell trait. And I think, my mom feels similarly. She feels like, I wish that I hadn't caused this in you. And I think as a child, I think of all my life and all the wonderful things that have happened to me throughout my life, and I wouldn't change that for anything. So I hope that when I tell my mom that, it brings her some sort of relief. Mm-hmm. But I understand, there is guilt in that sort of relationship.
And Dr. Shapiro, you're changing people's lives on this call, so your life matters. And just like Chris's did, Chris is still living on through the foundation, and those are the things you have to cling on to. You have to live on to hope like that, even if there are struggles.
Right.
Alexa, can we get a plug in here for our inherited mutations? So on the 31st of March, right? Is it the 30th?
No, it's 31st.
31st. On the 31st of March, we are having a webinar with, we call it the Talk. And we've done 3 of these last year, one for prostate cancer, one for ovarian cancer, and one for multiple sclerosis. And we take 2 people from the same family, one with a condition and the other without, and we ask them to talk to each other about their condition, and we have a moderator. And on the 31st, we are focusing on inherited mutations. And we already have one fantastic pair. Maybe Dr. Masoul knows this name. It's Dr. Pamela Munster, who runs the UCSF BRCA Research Center and works closely with Alan Ashworth. And Dr. P is BRCA positive, and she had a mastectomy and an oophorectomy. She has 3 kids. This was after. And she's going to be one of the pairs along with her son. And they're going to be interviewed by a genetics counselor, Lindsay Byrne from the Ohio State Comprehensive Cancer Center. She's also a professor there. And we are gathering the other pairs right now through Force and through Charcheret. And I'm not sure who's going to do the introduction. We were hoping it was going to be Sue Friedman from Force, who started this organization on inherited mutations. But I think she's going to be away. We may get her to record something. We're not certain yet. But tune in on the 31st, because it's exactly what Richie is saying. These are exactly the issues that we will bring out, I think, about how it feels as a parent of passed a germline mutation on to a child. So we are really sensitive, and we want to give all the support we can there.
And we have a question. Laurie had to leave, but her question was, are there any signs that RMC runs in the families?
Yeah, that's a great question. And this was actually one of the clues that told us that, you know, something more environmental, like high intensity exercise, may be a big risk factor. So we know that sickle cell trait, which is something hereditary, is, you know, a big mediator. It's a thing that you, in the vast majority of cases, you need to have to develop RMC. But we have not really, as far as I can tell, have observed a single case where RMC happened on the same family, even, you know, first degree relatives or second degree relatives, which was one of the reasons why we started thinking that it's not something, you know, that's purely genetic. Because, you know, a few years ago, like 4 or 5 years ago, we were thinking that it has to be genetic, because we were saying, why do some people with sickle cell trait develop RMC and not others? The easy answer, genetic. But then we realized that since we're not seeing these clusters, you know, this disease happening within the same family, even first or second degree, that's when that gave us a clue and said, maybe this is not, you know, genetic purely, other than the sickle cell trait association, and there are other things more environmental, like the intensity of the exercise, that are playing a role. So I hope this answers your question. Now, obviously, remember, we've only known about RMC since the early 90s, even though this disease, now we're finding out that it was, you know, first reported, even though it wasn't called RMC, 1982 in the scientific literature. But, you know, we've known about it since the early mid-90s. And then, you know, there were a few trickles about RMC. So it's not like we've been monitoring this disease for decades so that I can safely tell you, oh, it will never happen, you know, to your family members. So you always have to be a little bit extra careful, as with any cancer diagnosis. If, you know, a family member of yours had a cancer, you have to be a little bit extra careful yourself. But that certainly does not mean that that if somebody has RMC, their family member is certain to develop RMC or even highly likely to develop RMC. None of that.
Hi, can I ask something?
Absolutely. Go ahead, Lois.
Yeah,
Right,
but are you
okay.
going to ask it in Greek or are you going to ask it in English, Lois?
In English, so everybody can hear. Okay.
Okay.
First of all, lots of love and greetings from Fenina. She was awake some time ago, and she told me to tell you all the people there and the doctors as well. Many greetings and many thanks from here too. So my question is, what is it that determines the way that RMC behaves after a nephrectomy? I mean, that's basically for metastatic cases. I mean, can it have a life of its own in an organ after the nephrectomy? I mean, since the primary, the source is gone, where does it take, let's say, the power from? It's quite naive, maybe, in this question, but I'm just wondering, how does it behave? Does it depend on the organism, on each one? Uh, if there is some answer to that.
That's a great question, and boy, you've now opened a whole different discussion and a huge conversation that actually affects all of cancer research and our understanding of cancer. So I'll tell you this. Number one, unfortunately, because RMC is so aggressive, angry as a disease, in the vast majority of cases, it's metastatic, like even from diagnosis. At least, with the kind of not early enough diagnosis that we're doing. Now, are we seeing patterns where some cases are more aggressive than others? All of them are aggressive, but some more than others. Yes. For example, I mentioned before there's a 5 to 10% of patients who are cured. Why are these 5 to 10% cured and others are not? We don't know. But we are finding out, and hopefully in the next few years we will have more answers with regards to that. What is it that makes some RMC tumors behave differently than others? Now, your question though touches upon the very important concept of what is it that feeds the cancer. Is it the primary tumor? Is it certain metastatic sites? What's happening there? This has been a decades-long, possibly centuries-long debate and evolving understanding amongst cancer specialists. I think that RMC can teach us a lot here, and it's part of that, generating scientific interest, because RMC is a very unique disease that can teach us a lot about this. I do believe that when possible, if we can remove the primary tumor, it's a good idea to do so, but I'm very careful when I say when possible, because you have to be careful. If you do this the wrong way and you time it the wrong way, you're going to harm. Now, with regards to other sites, if it spreads in one area versus the other, and how do those play a role in how the cancer evolves, this is something we're still understanding. And I hope that in the next 5 to 10 years, we will have much, much more concrete answers to these very important questions.
Thank you. Really, thank you.
Hey, Dr. Masal, this is Andre Sneed. I had a quick follow-up question to that. So is there any consensus as far as in RMC patients, do you remove the kidney first, or do you start chemotherapy first and then try to remove the kidney? Because in my case, they went ahead and removed, my right kidney, and then I began chemotherapy. So I just wanted to know, is there any consensus on that within the medical community?
Yeah, and I'm glad you're asking this question. Again, I need to highlight that every case is unique. So that's important, and that's where expertise comes into play. That's why, you know, we can't just make recommendations for everybody and just let the people just use those recommendations. That's why we're always open to talk to people and physicians, mainly, you know, to the physicians of different patients to help out with our knowledge. And so you can't just make, you know, one ground rule that everybody has to follow. But having said that, in general, in most cases of RMC nowadays, and that's again an evolving knowledge, but nowadays we believe that it's better that we give chemotherapy first. And so in a lot of cases, when possible, we prefer to give chemotherapy. It helps us in multiple ways. And part of it is, you know, some people, you just remove the kidney first and their cancer may never even come back. I've seen that with some very rare patients with RMC. But we have seen a lot of patients who have had their kidney removed, and while they were recovering from their surgery, the cancer came back super aggressive, so aggressive that we could barely give any chemo. That's why in our latest consensus recommendations, so these are recommendations by experts from all over the world, we are generally recommending chemotherapy first. Then if you have a really good response, you need to time it well, you remove the kidney, then you do the rest. That's why it's so crucial. That's very different with how you manage other kidney cancers. That's why it's so crucial to diagnose RMC early and know that you're dealing with RMC. And then if you know that you're dealing with RMC as a physician, get in touch with the people who are experienced with this disease so that you know, you can get the optimal guidance and manage the patients in the best way.
So we have a question in the chat. Has there been any research into other cancers that family members have, even if it's not RMC? So an example would be if someone with RMC had people in their family, like a grandma, grandpa, or mom or dad who had cancer, but it wasn't RMC, could that be related?
Dan, you looked into this, so if you want to answer.
Yeah, we didn't really see a strong correlation between other family members with cancer and RMC. We specifically looked at other kidney cancers in particular because, you know, obviously RMC affects the kidney, and we only found about 4% of the patients in our RMC cohort that had family members with kidney cancer in particular. So it doesn't seem to be, at least so far from our knowledge, a strong correlation between other types of cancer that may be in the family and then developing RMC, which kind of goes back to our original hypothesis that, you know, RMC seems to have some strong environmental factors such as high intensity exercise.
So there are no, when you do your somatic sequencing, there are no mutations that would point to any type of precision medicine for RMC at this point in time?
I'll let Dr. Masoul handle that one since he's everything.
Yeah, and that is another beautiful question that is directly related to that paper I mentioned before that was published last year that did the molecular profiling. So here is what happens. The thing with sequencing is, and the type of sequencing that you're referring to, is that it's not, you know, just one technique that gives you an understanding of the DNA overall, a perfect understanding. So it's a little bit biased towards certain types of mutations. And those certain types of mutations, RMC doesn't have them. Like RMC looks very clean when you do those typical analysis. But, and that's why we actually thought that the genome of RMC years ago, we thought that the genome of RMC is pretty simple, other than the loss of that gene SMARCB1 that drives RMC INI1. But what we found out when we looked into this deeper, using more advanced techniques, you know, than the ones typically used in the clinic, next generation sequencing that is usually used in the clinic, is that RMC has a more complex genome than we thought. It just has different types of changes that you're not going to detect with the assays that you're referring to. That was a big deal, and it helped. Again, it started to unpack the mystery of RMC in a way, but then generated a gazillion more questions that now we're trying to answer to better understand this disease.
So
You
we
know
have
what?
about, oh, I'm sorry, go ahead, right?
No, I was just going to say, Dr. M, that when you were talking about how you're changing the ways in which you treat RMC, I mean, you're essentially a GU medical oncologist, and I'm sure you remember 10 or 15 years ago, nobody would ever dream of treating the prostate if you had metastatic prostate cancer, if you had de novo metastatic prostate cancer. Now, in the last 5 years, more and more, we see that you do the initial treatments. Maybe it's chemo, maybe it's a second-line anti-androgen, depending on the intensity of the disease. But then after a couple of years, you'll go in and you'll either surgically remove or you'll radiate the prostate.
That hits the nail right on the head. Could not agree with you more. One of my other major mentors is another Greek who is a GU medical oncologist here, a prostate cancer expert, Dr. Logothetis, who will tell you all about these stories, which inspire how we are also trying to evolve the field of RMC and other rare kidney and the common kidney cancers as well. Absolutely agree with you.
So I want to point out real quick, we have about 13 minutes left, and I want to swing by Diana and Danielle really quickly. Is there anything you need clarified or any questions that you need to ask or anything that was asked that needs to be reworded?
We have more questions every week or every month. We have more questions, but we will write for the next time, and we will try to send very interesting for us. And is that we have more questions about our own process, but we prefer to write it for the next time. And thank you very much for not only for the questions, for the answers. Thank you very much.
Thank you.
But if they email me, I can also ask Dr. Masal.
Yeah, I have to tell you guys, you guys are all amazing. You know, every single patient with RMC counts. We have learned, you know, even from Fenina's case in Greece, you know, as we keep seeing how things evolve, we learn. And we learn information by sharing that helps in every way evolve the field, both from a medical and scientific perspective, but even from a community perspective and the interactions. This is so important. I cannot emphasize this enough. It really kicks the field and makes it move, accelerates it 10 times more.
So guys, be sure if you have any more questions, I'm sure they'd be happy to answer them. If there's anything that wasn't asked or you would like clarified, we do still have some time left. And I guess one of the things I'm curious about, if you need some time to think, is what can we do? Because you guys are doing your job on the medical side. And if we didn't have you, I mean, we're all a team here. You're a very, very important part of the team. And I'm curious, what can we do as advocates, as patients, as survivors, as caregivers, as loved ones? What can we do to help you?
Well, the first thing I would say is this. You know, both myself and Nizar Tanir, we have seen many, many, many patients with RMC, and we certainly understand RMC more than many others in some aspects, okay, the medicine and the biology. But at the same time, we don't understand RMC at all in another important and key aspect, which is, how it afflicts families, or we understand it a little bit, but definitely not as much as somebody like, let's say, Ritzy Johnson, okay? And many of the people here in this call understand this. And that knowledge, sharing it and interacting with other people helps our patients so much. It is complementary to what we're doing and makes a tremendous difference with this disease. So I would say, please keep doing this. Please keep sharing. Please keep interacting. Please keep helping each other and us. That's number one. Number two, as we keep generating more knowledge about RMC and we share it with the communities, ask us questions as you're doing, interact with us, brainstorm with us. You may have viewpoints and experiences, that we may not be seeing. Like, Richard Johnson said, she was asking before, baby, why are so many people athletic? There is a certain point after which the stereotype doesn't hold that, every young person that's Black, will be athletic. It's, and you guys know this better than anybody. And so those kinds of insights are invaluable. And also, the way that we spread the messages to help people, how we communicate this, you guys may have insight on how to make it more effective and more efficient. So that's how you can help us. How can we communicate to the communities our message in a way that's the most efficient and does the most good?
That is great. Maria, I'd like to check in with you really quickly, since if you want to continue to just listen, that's fine. I just want to make sure if you had any questions. We haven't met before, so. She is muted.
Maria? And I also wanted to acknowledge April, because we know that you are the ace advocate amongst us. And we're hoping that you can turn some of this wonderful advocating ability that you've shown in Colorado to help RMC. Would you like to say something
I'm doing
about
as
that?
much as I can. Yeah, can you hear me?
Yes, we can hear you.
Are you able to? Okay. I do a couple of interviews a month, and every chance I get, I use the name of the cancer. I don't like for it to be clustered under cancer. I don't like for it to be clustered under kidney cancer. I like for it to be called what it is. And I just had a journalist ask me if there was anything I wanted from the last interview. And I said, yes, to call the cancer by the name, use the name of the cancer in the article. So every chance I can get, I say it. The state of Colorado, Richie knows, and Richard knows, the state of Colorado, where I was just living, passed the law, and they used my son as the poster child. So now everybody will have 12 weeks paid time off to spend with family members during this type of situation. So every chance that I get, I say it. I probably not the best public figure because I live a real life and I say things that are not always politically correct. I curse and I do things that, people do in real life. But when it comes to this situation here, I try as hard as I can to push the name.
That's fantastic. You're doing some amazing work there, and isn't it correct that they want to use your bill on a federal level as the model on the federal level for family care?
Yes, so Colorado was the first state to do it. So, of course, now nobody else wants to be left behind. So it'll start to branch across the United States. I just had an interview with the lady from, what's that, New York Times. and she's going to post it on her personal website, and she's trying to get it published in either that one or some other big name I'm not familiar with. But she's going to keep me posted about when that will happen. But as much as I can, I keep trying to say RMC, renal medullary carcinoma. I explain the link between sickle cell every single time. Like, if I could personally take a bat to RMC, I will beat the hell out of it. Like, I hate it. So I try to mention it as much as I can. My son's doing very good. His doctor is amazed. He's actually gonna have his kidney removed in about 3 weeks. However, we never know what's gonna happen. So if I can help my son, somebody else's daughter, that's what I try to do.
Well, you got a family with Richie in Richie. Make sure that you use that family, especially when your son's going through surgery.
Gotcha, will do. Thank you.
Can I put a plug in for the walk this month?
Of course.
Okay, just want to remind everyone, this is Kidney Cancer Awareness Month. We will be having our 8th annual Keeping It Renal Run Walk on March the 27th. It will be a virtual walk. The t-shirts are in. We've been shipping all over. I think I've spent over $500 worth money shipping. But we would love for you to participate. It will be virtual. Team Greece is in the house. They're ready. They're ready to go. So I think, hey, Maria, I think it's going to be a lot of fun. And it's just really exciting when we have people from all over the world. They send pictures in, they send videos. And I did post Dr. Masal today on his video, but it's going to be fun and we're looking forward to it.
Fantastic. Fantastic. You guys are an inspiration, all of you.
Oh, yes.
Oh,
Hi.
hey.
Hello guys, I think
Hey, Nicholas. Hi, Nicholas.
Dile hello. Hello.
But his
It
English is not better than our English. So very few words. Sorry.
Well, it has really been a pleasure having Dr. Masal and Dr. Shapiro on with us tonight. This is the largest group that we've had, so you are a draw. So we really do appreciate your enthusiasm, your energy, and we certainly couldn't make it without you. We appreciate that.
Yeah, thank you so much, both the docs for coming on and speaking. It's huge. It's huge to have that direct conversation means so much to so many people. So thank you.
And remember, this is being recorded. And if you think of any questions, maybe jog your memory tomorrow, you can certainly email Richie, and Richie knows where to find everybody. So you're good.
That's right. You can't get away
Thank
from
you.
What's the date of the
Very
next
much.
meeting? What's the date of the next meeting?
the next
Anybody?
meeting is April
7th? No, 6th. April 6th.
No, April 13th.
13.
April 13th. Sorry. Thank you. Thank
Okay.
you, Richie. April
Thank you.
13th.
April
Thank
13th.
you, thank you all so much for having us. And I tell all my patients, you guys do all the hard work. So it's been a real pleasure, and it's an honor to take care of you guys. And thanks again.
And Dr.
Thank you.
Shapiro, will you email me your address and send you your shirt?
Oh yeah, definitely.
Okay.
I was just wearing my one from last year, so.
All right. That's what we're talking about.
Richie?
You guys, you're supposed to wear orange this month. You see? This is Cancer Awareness Month.
Richie? Dr. Masoul, you wanted to say something. Come on in.
I just want to say thank you guys for all the, like this is so important. from the bottom of my heart, thank you.
We thank you.
Thank you.
We thank you. Thank
Great
you.
team.
Yasu.
Yes.
So
Yes.
can I just say, Doctor, am I okay to contact you then?
Yes, feel free to.
Thank you.
We try, you know, we try to be as communicative as possible with everybody. You know, it's very often it's easier to directly communicate with physicians. So, you know, with regards to specific patients, because it just makes things easier and less likely to cause confusion. But we're always open with people with physicians and patients. And if you want to contact about, you know, who might be interested in research, etc., always happy to help. Our doors and our emails are always open. And our chat through Facebook, as some people know, anyway, you know, we'll be happy to help. Twitter, whatever.
Brilliant. Thank you.
Absolutely. Absolutely. Thank you.
Well, you guys have a good night, and I will see you on the next meeting.
Okay.
Thank you so
Thank you.
much.
Thank
Thanks,
you.
everyone.
Thank you.
Bye-bye.